Hi, I'm David Lipscombe. I'm consultant in diabetes and joint clinical lead for the Diabetes Care for You service. I am a clinical consultant as my day job, and I also help to lead and manage the service alongside others.
My name is Ellie Rezazadeh. I am the Clinical Service Manager for the Diabetes Care for You service, working for Sussex Community NHS Foundation Trust. My role is predominantly around ensuring overarching governance, performance and delivery of the service.
I'm Stuart Adamson. I'm a Senior Analyst for Here Care Unbound, and we work in partnership with SCFT for the Diabetes Care for You service. We primarily focus on the reporting and data side of things.
The emphasis of the service is for the person with diabetes. It's not diabetes care for us as the healthcare professionals, it's diabetes care for you as the people that use the service. Our mission statement is to deliver an extremely good diabetes service. We believe there are 3 core themes that show the value of our service. The service and the team embody the NHS core values and the ethos of the long-term plan to ensure positive and improving patient outcomes. We use technology, both medical and data technology, in an innovative way. We utilise data dashboards to improve and enhance patient care and the efficiency of the service and our use of public money. The NHS core values are at the centre of our universe. We have a weekly multidisciplinary team meeting. The weekly MDT has everybody present. People who work for us, who work with our service, from the admin department to the healthcare assistants to consultants, specialist nurses, psychotherapists, podiatrists, dietitians. Everybody works together in that meeting to enhance our service, but also to discuss clinical cases, to make sure that we have the best approach that we can for people with diabetes. We feel it's important to share our journey and the lessons that we've learned with colleagues to support service development in other areas. We've done this in various forms. We've had an abstract in the Healthcare Leaders Conference utilising data dashboards. We've had a scientific letter to diabetic medicine that by the time you hear this presentation will have been published. We presented our service model nationally at the Diabetes UK conference, the Diabetes Professional Care conference. We are keen to show people what we've learned and to get their positive feedback.
We pride ourselves on having a really strong governance structure. Organisationally, we have senior managers who I report into to ensure we're managing risks, issues, raising concerns and also driving forward service developments. We also have monthly specialist meetings, as we're so multi-professional, where staff can generate ideas or raise issues or concerns so that we can drive improvements. We also have a monthly leads meeting where we're able to take those ideas of the team and begin to actually make things happen, sign off the direction of travel for the service and what we want to happen. Before COVID-19, we would also have a quarterly stakeholder meeting, so we had that engagement with patients and other third parties such as our CCGs, charities such as Diabetes UK and health professionals across the entire diabetes care pathway, so primary care, ourselves as a sort of tertiary care and then the secondary care services as well. And what that means is we can look at the entire pathway for patients rather than just looking at the one bit that we worry about or provide care for. We have also worked with other third parties to make improvements such as Healthy IO and doing a pilot project around urinary ACR testing in patients' own homes. We also started the service with monthly contract meetings with our CCG colleagues, and because the progress that the service has made, those have now evolved into bi-monthly service development meetings where we have their full support around developing, moulding and evolving the service. For me as a service manager, around how patient feedback is really important for me to be able to listen to that and make changes. So this isn't just about changes around the pathway or changes to staff, it's around changes for patients. So an example of that is I had a patient's wife contact me that her husband was struggling to access one of our locations because of a wall that was extending out so he couldn't turn his wheelchair to access into the room. This meant he had to travel much further for his care. She was highlighting it to me but fully expecting that I wouldn't be able to do anything about it. But actually we've been able to take that feedback back to our estates team, and we're now pending the building works to have that wall taken back so he'll be able to get the care in the location that he wants. And the wife really feels that is a massive change, because it's really not what she was expecting. And although that's the voice of one patient, all of our patients count, and that is now going to improve care for many more patients that maybe didn't feel they could speak up and raise that to us as a service.
In a recent Get It Right First Time visit to the acute trust that we work with, it was shown that across Brighton and Hove, we were number 1 out of 136 in terms of readmissions following a glycaemic emergency. In addition to that, we've shown very high levels of preparation of people with type 1 diabetes for pregnancy, and have some of the best HbA1c results for people with type 1 diabetes in the country. We have a strong psychotherapy service which is embedded into the physical health service that we provide, and they won the Quality and Care Awards for this last year. When larger pieces of work are identified, we give space to the team to work collaboratively to put ideas in place, and then give them the ability to actually carry them out and see the fruits of their labour. We are keen users of medical technology. We are one of the largest users in England of Freestyle Libre in people with type 1 diabetes. We were a pioneer of this and contributed greatly to the ABC, the Association of British Clinical Diabetologists Freestyle Libre audit. In fact, we were the test site for that. We are keen on, and have always been keen on, making technology accessible to people. People are sceptical about older people and technology, but we have challenged that assumption. We have many more mature people who use technology, medical technology, in their own homes to enable safe management of their condition remotely. We did this before COVID, but we've enhanced it since. We use home blood pressure monitoring in a considerable way. We use Diasend. We have urinary ACRs done in people's homes. All of this to enable safe delivery of care without people needing to travel.
One of the things we are most proud of as a service is our reporting ability, and how we've used our data to improve and evolve all aspects of serving our patients. I believe this is down to two things. Firstly, our technical setup and experience in extracting and working with clinical system data. And secondly, the close collaboration we have between the lead consultant, service manager and analyst. On the technical side of things, we extract all our System 1 data and import it into an Azure-based SQL Server data warehouse, and this happens via automated ETL processes every day. And SQL allows us to be more flexible with our data. It allows us to join and model more complex data sets that better suit our needs, compared to anything we could pull from the front end of a clinical system. The transformed data is then fed into Power BI reports for the team, which offers a good degree of interactivity and just a visually pleasing, easy to use environment for the team to explore the data. This functionality, combined with our control over what data we join together and put into it, allows us to create reports in which the team can extensively slice and ask their own questions of the data without necessarily needing the input of an analyst.
We've mirrored our Power BI National Diabetes Audit dashboard on many of the things that are collected in the national audit. That national audit is published once a year, but we can refresh our data on a daily basis, which makes it live and therefore very useful for clinical practice. It allows us to to subdivide our population in terms of their type of diabetes, whether they're using technologies, whether they're on a statin, whether they have an appointment coming up that things can be reviewed at within a reasonable window. We can subdivide again by age and sex, whether they've had the sick day rules or we know that they have a ketone meter, which in the time of COVID is extremely important in terms of reducing their need to go into hospital. So all of this allows us to both enhance the care that we provide, but also to target that care at particular groups that are clearly struggling. Most long-term services practice what I would call reactive care. So the patient comes and then something is done or not done. We practice proactive care, so we want to avoid a hospital admission. We want to avoid a complication, and we do that by knowing that somebody's target is higher than that which is deemed reasonable for that individual, and actively doing something about it before something happens.
The collaboration we have around any process that involves data is just as important as our technical setup and know-how. Getting together like this means we can design a process end-to-end so that it works for everyone. It means we can create less burden on clinical and admin staff around data entry. It means I know exactly what data to look for, and that the end result is an easy to use and interpret report. And this has had a great effect on user engagement and feedback, and as a result, our data quality. This collaboration is also very beneficial for patient safety. Our collective perspective when designing a process means we can better spot any gap in a process or change where an error could occur and result in a delay in patient care, for example. Working this way has just generally improved our efficiency and our ambition.
So we have a plethora of business intelligence dashboards that Stu has built alongside with us. Those range from contractual performance dashboards, so that allows me to monitor our key performance indicators and our metrics that we have to report on within our organisation and externally to our contracting colleagues. We also have patient safety dashboards. This allows us to ensure patients are booked from the correct waiting list, that they're booked into the right appointment type, that they're not lost to follow up, that they are followed up at the right time. So recalls are generated for our admin team to be able to then process. We also have operational performance dashboards, and those are the ones that I use most as an operational manager. They allow me to really drill down into the detail of what's going on in the service. So whether that is referrals coming in, who and what we're discharging and why we're discharging, what are the staff doing, what's our new to follow-up ratio, have we got the right demand and capacity going on in the service. We also have clinical performance dashboards, so we have our HbA1c tracker, which allows us to check patients at each end of the spectrum are getting appropriate management. Have we got people in the service that we don't need to have in the service, and provide assurance that those at the top end of the scale are getting the care that they need. It is all down to Stu really and what he's able to do, and make it an attractive way for me to be able to understand it. So I'm really excited for the future with some of the innovations that we've been using through the COVID-19 pandemic that we hope to retain to further enhance our service, but also looking forward to maybe sharing the message more widely about our service model and what we've done and potential expansion of the service.
We believe that we have achieved our mission statement of providing an extremely good diabetes service, but we don't want to stop there.
We've added value, not just financially, which the evidence is there for, but it's around what patients want and what there is that wider acceptance and buy-in that this is the way that services should be delivered.
I've found that our use of patient information in the way that we've done has been, for me, nothing short of revolutionary, and I don't think I could ever go back to working in the way that I did before. We're working with partners within industry, within the NHS, within the universities to make the care that we provide as good as it possibly can be for the people of Sussex and hopefully beyond.